name is Chesya and welcome to Arise. In this series, we're talking about sexual and gender-based violence. And today, I'm here at the UTH Gender-Based Violence One-Stop Center. And inside here, we're going to learn more about what they do. And I'm here to meet a very special person, one of the members of staff who works here, Dr. Rokaya Ginwalla. Come inside with me. Hello.
Good
Hello,
afternoon.
Hello, how are you?
Fine, and how are you?
I'm very well, thank you. I'm so pleased to be here because, just meeting you, for me is just something that has been so special because we go a long way back. There's a special connection, of course, from
Equally
many years
pleased
ago.
to meet you. Yeah, I've heard so
many
much
years
from my
ago.
sister about you. Yes.
Thank you.
Yeah.
From many years ago, the connection with your sister Aisha.
Yes.
But then, of course, the other thing is that you're involved in work, which I'm
Which is
very passionate about. And that's what I would like us to talk about today.
Yeah,
So
grateful
maybe-
that you could make time to come and have this conversation with me. We need a lot more people to know about really what's going on and what services are here and how we can help them. So I'm grateful that you could find time to come as well. Yeah, thank you.
So first of all, perhaps you could tell us a little bit about yourself, how you got into this area of dealing with people that have been abused, and just
I'll start with a general introduction. My name's Dr. Rokaya Ginwalla. Been based at the University Teaching Hospital for many years now. In fact, most of my working life has been here in the Department of Pediatrics. And I specialized in pediatric HIV. That's my specialization. And I think I worked with pediatric HIV for more than 12 years and then moved on to, for the last 7 years, I've been working with gender-based violence. And we see a lot more children who are sexually abused compared to adults. But I've ended up being working here. My background also, I grew up in Mazabuka, born and brought up from Mazabuka, as you know. That's a home for me. Yeah, that's about me. And then I can say how I ended up working in this department. We had an arrangement that the pediatricians did a rotation and they worked part-time. There were about 4 of them who would come in, see clients, sign the police form, because about 2-3 years ago, only doctors were allowed to sign the police form. So even if the clinical officers were present, they couldn't sign the form. Only the doctors had to sign the form. So there were doctors attached to the department who oversaw and signed the forms. Unfortunately, the arrangement for part-time was stopped due to funding issues. So then there was a gap and no one was available to sign the forms. So actually the clinical officers who were running the department came to me one day and said, please can you come and help us? When they were busy over Christmas, New Year, even while I was working with pediatric HIV, I used to come and help them. Every time there's a holiday, the center gets so busy. So I would, when you are knocking off, you see them still with a long queue. So I would remain behind and try to help them finish off with the clients that they were seeing. And that's how when the clinical officer approached me to say, please, can you help us? We have such a big backlog. I volunteered to just help them out, and then by default I was told, just stay there, you're not moving. Of course, I wasn't very happy about it initially. It took a while to come to accept that now I'm going to be here permanently, because I just volunteered to help. I was happy with my work in pediatric HIV. But I came around it, and since this is now more than 7 years since I've been here.
That's quite a long time.
It's a long time,
So in terms of the one-stop center here,
yes.
How many cases do you sort of see over a month?
Okay, so we see cases, adults, children, boys and girls, okay? So I would say children, we see about 80 to 100 every month, and adults will see about 10 to 20. And so from those 80 to 100 children we see, a few are boys, maybe 2 or 3 boys every month. So the majority are young girls, but mostly it's, even with the children, we have the age groups. The adolescent age group is more, we see them more frequently. I would say almost 60 to 70%. It's in the between 10 to 15 years. Then about 15% it's 0 to 4, then 5 to 10 years, another 20%. So yeah, that's about the breakdown. And with the boys will be about a 1 to 2% boys on the whole picture, young boys, yeah. Men don't often come in, never report. We hardly
but there
ever.
are, there are
Yeah,
cases of
they
men
can be
who are
men who can
sexually
be, yes,
abused.
yeah, but reporting sexual abuse in men. They do report maybe physical abuse. Yeah, if they've been beaten once in a while, but even that is not often. Yeah, and then yeah, women come here quite. Yeah, but compared to the biggest age group is the children and girl child.
So you're talking about 120,
So these are cases
roughly
of sexual violence only. I'm not talking about physical violence, partner, other forms of violence, but just sexual violence cases, or at least suspected cases of sexual violence, who end up here. Our one-stop center is, we can't handle. If we had to take on the physical violence cases, we would be overwhelmed. Yeah. So mostly it's sexual violence.
But that is alarming. And do you think that is representative, like from across the country? I mean, if you have reports from other, health centers.
It's very underreported because often these cases, it's somebody close to you. So within the family, if it's somebody you know, the first thing is you don't want the public to know about it. You hush it down. You try to talk to the person. It could be an uncle, it could be a nephew, it could be a neighbor. So normally, a lot of times the literature or just the statistics, generally it's assumed that for every one case that's reported, 10 are not reported.
My goodness.
So when you see one case, you should know that there are other 10 that are sitting out there that have not been reported. Yeah.
That's
So
frightening.
that's frightening. Yes, what we see is just the tip of the iceberg. Yeah. And then while we are talking about numbers, there's an impression now that we are getting a lot of cases, but I would say that it's happening. It's just that people are more aware, so they go straight to the media, they go straight to report, so they are more aware about their rights and about the reporting. But in terms of numbers, I wouldn't say that. There's this thing that in the media they'll say, oh, they're increasing cases, but really, if you look at the trends, we do get the police statistics which show sometimes up and down, but I think this year they were slightly lower than last year. But generally, my feeling is that it's just that there's more awareness, so people know their rights. They go to the media, they go and report to movie TV or somewhere. Yeah, so yeah. And some of the cases have received public attention, through social media and things
social
like that.
media,
So it looks like there's an increase in the number of cases, but really, if you sit here, you see that that's really how we see. This is how serious the issue is, and we see a lot of cases every year. Yeah.
I'd like to come back to the point of your work with the police, but maybe before we speak about that, with the cases that do come in,
Yes.
what sort of injuries do you see?
Okay.
The people that you
Yeah. So one thing about injuries with sexual violence, it's not always that you find an injury, which is very partly because people almost like 40-45% come late. Because first they're trying to negotiate at home, or they're trying to look for transport money, or they're trying to, and that delay, or they go to the police, then from the police to the health center to the next level, and each referral point means money for transport. And by the time they come here, we examine them and we find there's no injury. Yeah. And also by virtue of being, if you are prepared for the sex, this is sexual violence we are talking about. So if somebody like a teenager is primed, like enticed, they use lubrication, there's something that maybe even given alcohol and things like that. So you may find no injuries, yet the sex happened. You know, they were abused, but I will examine and I'll find nothing. I won't have enough proof to say. So it's not always that there's an injury. Yeah, so which brings me to the point of right now we are also doing DNA testing. So if, yes, it's one of the newer tools we have. It's part of the whole evidence and forensic evidence that we collect. So if we don't find any injuries and somebody comes in good time, then we can take samples of to see if we can find the perpetrator's DNA on the body of this person, or if they left semen, we collect that semen. If they touched, if they left hair, if they were sucking somebody's breasts, we can swipe to look to get the saliva, things like that. So if people come in, report early, don't bath, keep their clothes. We even put their clothing in a bags and send them for DNA analysis. So there are a lot of the weapons. I mean, there are a lot of other ways of finding out if really something happened or not. It's because many times you don't find any physical injuries. Yeah, it's not.
I think that's a very important point to keep bringing
and
out.
that especially for those who are already sexually active, you know, those who are married or maybe they have already a relationship and then they're raped or taken advantage of. Then it becomes harder even because these are sexually active women. You will find tears in the hymen because they're old tears, which was a sign that they are sexually active. And to find a visible injuries can be difficult.
You spoke about having young children, that is babies, maybe adolescents. Now, if they've been raped, when I refer to the injuries, I mean, what are some of the long-term effects of like the rapes if there were severe injuries, for example?
So some we have cases where they have fistula, you know, where they develop an injury that goes right through, cuts across the urine, the stool, everything passing through one place. You know, there's no control of, so we can get severe cases like that, But I think so the biggest trauma is the psychological trauma for most of these children because they are traumatized and then the adults try to negotiate for them. Nothing happens, they don't get counseling, they don't get any support. They grow up and they have to get married and get involved in a relationship. And it's very hard when you've been abused to now get on, you know, to have a sexual relationship with someone. So the psychological trauma is very, and these are the same children who become rebels. Either they even become overly sexually active themselves, or they become perpetrators themselves. You know, they become. These are the children that will say Sibambera, you know, in the community. Sometimes we need to investigate, something is behind. Yeah, we have children who don't listen, who don't fear anything, no matter what punishment you give them. But behind it is some abuse that happened. Yes, they're hiding something. So that long-term psychological consequence, we tend to neglect it, and like a lot of times there's no follow-up, there's not enough support for these children to be really truly come out of what that trauma that they've had.
Now, for the cases that relational have happened, like abuse has happened within the domestic arena or community, somebody known to them, how do you handle those? I mean, are you able to counsel the parents? And I don't know.
Okay, What we have also this I give an example of children who abuse children. So a nephew, maybe a 13-year-old boy, he's just becoming sexually aware of himself, huh? And then he abuses his own nephew, his own niece, or his sister, or someone. So that kind of familiar thing within the family or someone very close, if they are below the age of 17, they need a lot of counseling. We also try to explore if they have themselves been abused by somebody older, because sometimes they imitate what they've seen or what has happened to them. Then they'll try and imitate it and do it to somebody younger than them. Yeah, so that is a common habit. So we bring them for counseling. We explore whether somebody has abused them as well before we even. Yeah, and then they need what we call a diversion program. It's not a very active program in Zambia, but there is something like where they get counseling and support to try and make them aware that this is not the right thing. And yeah, it's not a very strong program, but it's there. It used to be much stronger in the past than it is now. Yeah, yeah.
Yeah, this is, this one-stop. What is the one-stop
Yeah,
center? Maybe you could
that
just
is
tell me a
also a
little bit about.
good question. Yes. So, when I was practicing and when I graduated, what we had was if a child was sexually abused, they were brought here and taken to the gynae ward. Now, the gynae ward is a very busy ward. There are mothers delivering, mothers having miscarriages, big women. And then in the middle of all that, a small child is brought, there's blood going, those wards are. And it was so traumatic for the child to be sent to a ward with the adult females being examined. And some of them might be, screaming over some pain or something, and you know that this child is being examined. Then from there, they would be sent to the police. Then from the police, they were sent to psychiatry for further counseling. So they had to move around this big hospital at different points. And that was, I think we came to realize it was a wrong thing. Somebody did a study, and one of my colleagues, actually, Dr. Mwaba, Kasese, she actually did it as a study as part of her research, I think, and tried to bring all the make it all into a one place, all the services in one place, and that was the birth of the one-stop center. So instead of shuttling this child, and the people even gave up, you send them for an X-ray, they go home because it was too much movement around this big hospital. Yeah, and that's how this one-stop center was born. And the first one was here at UTH. So we had engaged police officers to be permanently based here. We have psychosocial counselors. We have nurses who are also trained counselors. We have social welfare services, and then the medical services. We lack legal aid here, though they're very close to us because the NPA is just across the road from us, and we do communicate with them over cases that we have, but we don't have a permanent legal person in our midst. Yeah, but that makes it much easier because we do everything from here. We do all as many lab tests as we can from here, all the counseling, all the medical support, collection of samples, labs, everything. So when they come here, most of them will only come here. If we send them out, maybe if we need an X-ray or we need to do an ultrasound or one or two investigations. But most everything is done here and they go home from here. Then the police form is signed here and our police will take care of it. Even that will be delivered to the police station, respective police station by our police. So once they come here, they don't have any other responsibility of go here, go there, go there. They just have to come back for review. Yeah, we don't shuttle them from one service to another.
I think that's
so
very
that's a very
comforting,
good,
for a person who has
who's
experienced
so
trauma,
traumatized
because
already.
UTH itself is
It's
so
such a big,
big, and then if you have to go from different department, it can just be add
So
to the
that was,
trauma.
So that was how, and then from this one-stop center, I think this model was replicated in a lot of provinces. We had one in each province. Now we have many centers in most of the districts. And a lot of the clinics now have what we call a gender desk, so that when or identified people who, when there's a case of gender-based violence, they know what to do with it. So the minimum services are offered to them, even if they don't have police officers, even if they don't have counselors, but they know what the minimum service is and they're able to handle the case before they send them to the next one-stop center. Yeah. So things have really advanced. Yeah.
Absolutely.
Yeah,
I
it's
mean,
good
I
to see.
came to know about it
Yeah.
because I came with somebody here.
Yes, yes.
I didn't know there was a,
Okay,
which,
okay.
we need to talk about
Yeah,
how you
yeah.
talk about it and the
Yes.
media campaigns that you
Yeah,
do.
yeah,
But first of
yeah.
all, I'd like to find out, like, when you have people that have come to the center, do you have any follow-up mechanisms? Because
Okay.
obviously this is something traumatic that has
Yes,
happened,
yes,
especially if it's
yes.
within the family.
Yeah,
So what
yeah.
mechanisms do you have, like, to
To
follow
follow.
up and just to,
Okay. So
check that they're doing okay?
we have a schedule for them to come back to us. Um, So generally, okay, prior to COVID, we used to see them like as 2 weeks, then 1 month, and then 3 months, 6 months, yeah. But once COVID hit, we kind of reduced the review dates. We tell them to come anytime. The center is open, but they have a scheduled reviews at 6 weeks, 3 months, 6 months. And then that's just the regular schedule, but we also look at individual cases. If somebody is very traumatized, and because you find sometimes the child doesn't even know what has happened and doesn't even understand, is not really traumatized, but the parents need more counseling. The parents are the ones who are more traumatized. So we look at all that. And if the child is traumatized, they'll come more frequently. They come the next day, the day after, the next week. And then also the capacity for our staff is also limited. If we see that this is something that's beyond us and they need significant other support, psychiatric support, then we refer them to, we have a clinic 6 here where they also help us with cases that are severe trauma cases. So our social worker and the counselors, they have a checklist, so they go through that and they're able to say this person needs further referral, and then they send them. They send them. They know who is beyond the, the what they can handle. Yeah. Yeah.
On that point, how do you, I mean, you have the person who comes in as a patient
Yes.
or client.
Yeah. Yeah.
How do you
We
then
call them survivors.
survivors?
Yeah.
Yes,
Yeah.
yes. How do you then support, for example, the
So
parents?
then,
Because you've spoken
yeah,
about that
yeah, the
sometimes the
parents,
parents are
yeah,
very
we
traumatized
have to
and they
count.
can
We
re-traumatize the
yes,
survivor.
yes. So we have to then counsel the parents as well. They also need their own counseling, yeah. So, and what we do here is we separate also the child from the mother. We get the story from the mother. We separate. We do that as well to try and see so that we don't influence this one being influenced by the next person. So we do separate them. We talk individually to the parent. We talk individually to the child. Yeah. Yeah. And then in terms of other support in the community, so we do sensitizations out in the community.
Yes, I
We
wanted
go
to
to,
find out
okay,
about
yeah,
that.
we
Yes.
have deliberate efforts in different places to do, go in the community and sensitize them. We target teachers, church leaders, community leaders, that kind of people, yeah. Police as well, and also we work closely with the Zambia Society for Child Protection. It's an NGO as well that helps us to track people in the community. They have counselors based in the different sections of Lusaka. They have quite a wide areas that they take care of. So for those that we know they can't always come back here, so when we ask them that please send your counselors to this home, let them follow up this child, and also they'll also check on whether they're taking medication. Have you finished your post-exposure prophylaxis? Because one of the things we give them is HIV prevention treatment, which we call PEP, post-exposure prophylaxis. So these are the agents who go in the community. They do some counseling, check on them. If there's any problem, they'll bring them back to us as well. Or they'll give us some feedback on what's happening in the community. So we work closely with them as well.
That's good. Do you speak with traditional leaders at all? Because I
Yes.
know that there's a lot of abuse
Yes,
in traditional areas, in communities, rural
we
communities.
work with the communities within Lusaka, but I'm not. We are limited to the urban setting. So traditional leaders, we do have sometimes workshops, but we've had some engagement with them. Like, there are a lot of chiefdoms that are declared GBV. They're gender sensitive and they do a lot of work. So we do get invited to come and speak when they're having these chiefs meetings. I remember there was one in Kabwe where we went to speak about gender-based violence. So occasionally, yes, we do, but I think being Lusaka and the setting here is a little bit different from the traditional setting. I'm sure my colleagues who work in the southern, eastern, and western and other provinces, they probably have a closer link with to working with the traditional leaders than we do from here.
What has
It's
been
more
their
because of the
reception to the information?
No,
that
they are
you've given?
very. In fact, they are very good influencers. How do you say it? Especially because we also had this whole issue of child marriage. When we incorporated the chiefs, they were very, very in the forefront. If anyone was involved in child marriage or if they had anything, they would be reported and the chief would summon them and things like that. So I think it's very positive. We just need to keep engaging with them because they do help us when There's also there was also an initiative where we're trying to set up some one-stop centers in the community so that people have access to the basic services quickly.
That's right.
So these were called community one-stop centers, and it was a joint UN, US government, and I think Swedish funds, Belgium, a whole lot of NGOs who combined together to set up some of these community-based one-stop centers here, which were run by the community, and then they knew how to refer them to the next level. And but don't know now with all these funding issues how active they are. But it was a good initiative as well, just so that the services are closer to the people. Because I've been to places where just between Lusaka and, like, if you go to Kabwe, before you even get to Kabwe in Kapiri, and you're in a fairly remote place, and then the closest police station is maybe in Kabwe, and they're in between Kapiri and Kabwe. It's very hard for them to, where do they go? Then the cases, they report, but the police station is so far,
so
they
far.
need to, so then
So, and even with that distance, then there's
they
the
would
very
just,
fraught
it's,
aspect of losing evidence.
yes,
right?
yes, and if it's easier to negotiate and get paid something and forget about it, so the adults will negotiate on behalf of a child who's then traumatized and lives with this trauma and nothing has been settled, yet someone gains. But the reality is we really need more services really close to the people. We've done well in terms of most of the health centers around the country now have some kind of gender. They're gender aware and aware about these gender-based violence cases. They have somebody who's specifically assigned to
deal
help
with
them. There's a team who's always trained for so we've seen a great improvement in access to services, especially in health centers. But the disadvantage is if you are far from a police, far from a health center, then it becomes difficult.
From our conversation, I think going forward, it's something that maybe we need to engage other people, a lot
Yes,
of people,
yes, a
because
lot
I
of,
see
yeah,
that, first of
yeah,
all, you talked about support coming from, you mentioned a number of like
yeah,
USAID or,
yeah, yeah, the
so there's
UN, yeah.
need now to really involve
Yes,
Zambian
yes,
institutions,
for us
Zambian
Zambians
companies,
to
because
be,
this is a
yes,
problem in
in
Zambia.
Zambia,
So we
yeah,
need
no,
to really focus
yes,
more on getting the word out about how
yeah, yeah,
serious the problem
yes. I
is.
can tell you I have the worst case that I've seen is a case in Kapure. And up to now, I've been talking to many media places, Zambia Daily Mail, Phoenix, Radio Phoenix. I've been on a lot of radio programs. I've asked people, come and do a documentary on her. Because she was abused when she was 13. She's now 17, bedridden, with a urine bag, with a colostomy bag for stool, sitting at home. And this is a result of sexual abuse. She was gang raped all those years ago. And nobody's interested in coming forward and doing this. So I even tell them, when I go to BBC, you'll accuse me that you've left the Zambian media, but I'm ready to go to BBC because no one is interested in her plight. I have to personally look for donations to buy her medical supplies because nobody, no, I have to use my contacts and beg for money so that some people can give me something just to support her.
And
But
this is a Zambian
and
girl
she's
in
and
Kafue.
not 4 years down the line, she's not even on social services. Talk to Ministry of Education. We'll find out if she's under social welfare. We'll see what we can do. We've talked to Minister, is it Tayali, somebody? Everybody says they'll do something. Talk to the gender desk, what's her name? But people, no interest here. So you think like, who's responsible? I mean, what are we doing for ourselves? Yeah, it's very sad. It's very sad, yeah.
I think
But
that's something that really needs to be researched.
yeah,
Is
yeah.
there an innate problem in us that is
We
refusing to
should just
face the
wait.
issues of
Yes,
sexual and
yes,
gender-based
it is. We
violence?
shouldn't wait for donors to come and we don't want. I don't want to go to BBC to come and do a documentary on this girl. I wanted the Zambian media to come and highlight the plight of this girl, but I'll be forced to go to outside because no one is interested. And then they'll say, "Oh, why are you doing?" Yes, but you see what I'm saying. That yeah, we should. There's no ownership. Yeah, and I feel very bad that all these years later she's still not on social welfare. The mother is a single mother looking after. She has her own children. She's trying to do business, and then she has this disabled child in the house, and still not on social services. Yeah.
That's a
Yeah, that's very
horrific
sad.
story.
Yeah,
Yeah,
it is. Yeah.
yeah. No, maybe something that we could speak
Yeah, we
about
can talk
more.
outside of this.
Yes,
Yeah.
yes. We've spoken a lot of things. Maybe you could just tell us, like, when somebody has been raped and they come to the center, apart from the services that you've spoken about, the psychosocial, how do you help them immediately?
So immediately, okay, apart from the psychosocial, we have, at the center, we have police officers who will open a police case. Okay, so the docket can be opened from here. The nurses will take all the demographic details and find out exactly what's happening. We do the bloods to check for any HIV, other STDs, including hepatitis, syphilis, any other diseases. Then, as medical staff, we'll take a history. I told you, separate from the parent and separate from the child. We don't talk to them together unless they're very young. Then they'll be together. Then we do our examination. We document everything we have. Then we'll provide post exposure prophylaxis for HIV. so that we prevent the HIV. And we can only do that within a window of 72 hours. If they come after 3 days, it's too late.
So it has to be within the
Yes, yes,
72 hours
yes.
that they receive this.
Yes, yes, yeah. They need to, under the Zambian laws, we are allowed to give emergency contraception. But under the, now that with US government, it contradicts the contraception. But we that's one of the services that they are eligible to get, so they don't
This is
get
to
pregnant, to
prevent
prevent the
pregnancy.
pregnancy, yes. Then if they have any, we also routinely give them prevention for STIs because we don't want them to have fertility issues when they grow up, especially the girls. So presumptively give them treatment for sexually transmitted infections. Yeah, so those are some of the things that we do. And we collect all the forensic evidence. If they come with a blood-stained pant, if they come with a cement-stained underwear, if they come with, we'll take swabs, we'll do everything we can to collect any evidence, pubic, if the perpetrator leaves pubic hair or anything that looks like it's evidence for us to, we send it to the DNA lab. So we work closely, very closely with the lab at Levy, the DNA lab.
Oh,
yeah,
that's
yeah. So
exciting. That's an
they
exciting
are
aspect of
supporting
it.
us well with
Yeah.
the
Yeah.
yeah. So those are the services, and of course then we need to long-term follow up and see what's happening. Some of them need to come earlier for review depending on what kind of injuries. Some of them also the psychological state. They might need to come back for more counseling. Yeah, yeah, and then referral as well. We refer to outsiders. Some of them may need to be in a safe home. So the social welfare will help us through IWCA to find a safe home for them. Yeah, yeah. So those are some of the, and also court. We go in court as expert witnesses to give evidence, and we also prepare the child or whoever, whether it's an adult or a child, court preparation, even take them to court to show them what the court looks like so that when they are called, they know what they're going for. Yeah. So our social welfare officers are trained how to prepare children for court. Yeah. Or survivors, I should say survivors.
A lot of
Yeah. Yeah, a lot of,
amazing work,
thank you. Yes,
wonderful
there's a
work
lot of
here
things going
that
on.
a lot of us out
Yeah.
there don't really know
Yeah.
about.
Yeah.
And I hope that
And
people
it's
will
a
get to
very
know more.
busy place. I can tell you,
Yes.
working here is
Yes.
not. Yeah.
Yes.
There's always a.
Yes. Yes.
Yeah.
Yes. But one observation I had is that, the location of the one-stop center,
Yes. Yes.
it's kind of a bit in the open. I mean, how do people
Okay.
feel? Do people feel, a reservation to come here? I don't know. I
People.
mean, have you
Yeah.
received any feedback
We
about that?
have
Yeah.
received.
Yeah.
Some people have said that it doesn't look nice. We don't like. Have said that, but the survivors themselves have never complained. But outsiders say that, oh, you have such a big, such a big label, on the wall to say One Stop Center, UTH, Sexual Gender-Based Violence Center. But most of the survivors, I think, when they have never complained,
Never
it's the
complained.
outsiders
It's
who
the
feel,
outsiders,
yeah.
okay.
So unless we haven't found anyone has really said they didn't feel comfortable coming here.
Okay.
Yeah. Most
Maybe
of
it's
them come.
part of
It's
demystifying, and
as well.
the stigma aspect. Yeah.
Around it.
Yeah.
Yeah. But I think the survivors themselves have
Don't
never
have any
said that,
complaint.
oh, we didn't,
They're just glad to
unless
get
they
there.
just never came and then we don't know. But those who've come have never said, oh, it's not, it's embarrassing. Why did you put it like, that never. Yeah.
Okay, there's one question that I would like to ask you, Dr.
Yes, sure.
Rokaya, is that this is such a difficult, subject, and very emotive. There are deep feelings concerning this topic.
Yes.
How do you, as Dr. Ginwalla, feel about it? If you can give us just a little bit, because even through my own work, when you've spoken to people that have gone through very traumatic circumstances, sometimes you carry it on and you can go home and feel depressed, a bit low.
It's a big burden. It's a big burden to carry. Yeah, it's not easy. you think about all the different cases that you see. It's also traumatic for me. But my way of distressing is I get involved in a lot of sporting activities. When I go home, I try to take a walk every day. I do hiking, cycling, swimming. I do activities that that give me a bit of a refresher. Yeah, but it's a heavy burden to bear. I've actually begged to be released from this department so I can rest and go somewhere else. But I think after 5 years of working here, I tried to ask for shift, but no one is really.
It hasn't happened
Nobody
yet.
is ready
People
to.
treasure
Yeah.
your
No, and
immense
people are
experience.
scared of going to court.
Okay.
Most of the doctors feel like, oh no, I can't do that. I can't go to court. So that the court is what makes most people afraid to come here. But yeah, it's not as bad as they think it is.
But you also have to have a passion.
Yeah, I guess
because if you just treat it as a job, then
it's not the same.
It's not the same.
It's true.
Yeah.
But I try to distress in my own way, and I think because of that, I seem like I'm a very serious person. I don't have time to be overly friendly and overly jovial. Because I think you carry a heavy burden. There's a lot of different traumatic cases that we see here. It's not easy.
But I mean, I've seen you interacting with people that came in, and I just see the softness, and the compassion,
I try
on your face. So I think you're in the right place, and as long as you're able to de-stress and take time off, it becomes a passion, right?
You come to create a balance and try to, when you go home, think about other things and get busy with other things. I'm also passionate in farming, so I try to spend time in the garden planting things. So those are the way
that's the other side of Dr. Ginwalla.
Yes. Sports and gardening, or farming, I should say farming. It's not so much flowers, but more the crops that I plant. That's my other hobby.
It's been a pleasure.
Thank you so
talking
much.
to you,
Thank you,
Dr.
Chesya.
Ginwalla. I mean, I've learned so much, and my passion, is just even ignited. Just how together we can support anybody that has been, abused. How we can help them. Yeah. Thank you so much.
Appreciate. Thank you. Thank you very much.
Thank you.
Really great to meet you.
Lovely to meet you too.